So I'm Pal Roach. I'm on the board of directors of Black Health Matters. So I'm my honor to introduce this session. Uh, Today we're going to cover men's health. Let's talk about prostate cancer, erectile dysfunction, and BPA and BPH. Sorry. And with us today is Dr. George A. Johnson. Dr. Johnson has over 40 years experience. He's a partner at New Jersey Urology and Summit Health, and he serves as chief of urology at Carewell Health. And he's been a long-time strong advocate for men's health. We fully expect Dr. Johnson will provide us with the information men need, we all need, to know about these topics and have be better informed patients in men's health. So, round of applause, please join me in welcoming Dr. George Johnson.
So let's start with a little anatomy. It's a good place to always try and gain a little understanding about what it is we're talking about. So this diagram here, fortunately we don't have a pointer that works here, but so this is a cross section of the male pelvis, okay? As you can see, these are some of the important structures that we're going to talk about. Here we see the cross section of a bladder. We see below the bladder this organ that we're going to talk about called the prostate. And as you see this tube that leads down through the penis, that's called the urethra, and of course the testicle. And this is a little structure here called the seminal vesicle. When you do a vasectomy or you cut that, that's to prevent pregnancy. And what we don't have in this diagram are the kidneys, which are located up here. It's connected to the bladder through these tubes called the ureters that runs down to the bladder. So what is the prostate? The prostate is an organ, typically the size maybe of a walnut. It can be larger. It can be as large as a small orange. And this organ, which sits below the bladder and is connected to the bladder, is part of the urinary system, as well as the reproductive system. And we're going to focus, though, on the urinary issues. This prostate forms part of the tube called the urethra, which allows urine to run from the bladder, through the prostate, through the penis to the outside. So it is a conduit. It's part of a channel that allows urine to move from here where it's stored to the outside. It produces a fluid when men ejaculate. The source of that fluid is the prostate and this little structure here called the seminal vesicle. What's contained in the ejaculate? Sperm, which comes from here, which is basically travels down this tube called the vas deferens. It mixes with prostatic fluid. So when you ejaculate, you have fluid from here, fluid from the prostate, and of course sperm. And that's what is contained in the ejaculate. Okay. So this little gland that basically commands so much attention, and we are going to focus on some of the disorders that, again, plagues many of us. And we're going to start with BPH. Now, BPH, again, stands for benign prostatic hypertrophy, benign prostatic hyperplasia. And it has to do with the enlargement of this structure called the prostate. And as a result of that enlargement, certain symptoms develop. That enlargement, because of this location, will cause sometimes the restriction in the flow of urine. This tube that runs obviously as part of this gets squeezed, constricted, and as a result, the flow of urine is slowed. But also, as this gland enlarges, and it starts in the fourth decade of life, so in your 40s, symptoms of BPH will start, and we'll go through those symptoms, and will progress as we get older. Not everyone will have issues with this progressive enlargement, but many men will. Prostate enlarges, it starts to impinge and push on the bladder, and that is the reason we get some of the symptoms that we experience with BPH. And what are those symptoms? Men begin to experience frequent urination during the daytime or waking hours. You're finding that you need to go to relieve yourself or urinate more frequently. Every hour, every 2 hours. You may find at night, nocturia, you're waking up more than 2 times. You also have this urge to go to the restroom, to urinate more frequently. The force, the quality of the urinary stream is diminished. You hesitate. You may go ready to start, just doesn't come. So you have to sit there, and then the flow will start. And that is related to the enlargement of this gland because it's sitting in such a critical place. Things can get progressively worse. There can be urinary tract infections as a result of this enlargement, blood in the urine, hematuria. It can progress to the point where the enlargement causes retention of urine. You can't urinate. And that requires placement of a tube called a catheter to drain the bladder. And of course, obviously, then there's going to be a discussion about treatment, what to do. So, BPH, benign enlargement of the prostate, we start to experience frequency, urgency, diminished flow, nighttime voiding, and slowing stream, and then it can progress to the point where there is total retention. Unfortunately, when that retention develops, that the bladder obviously is affected because the bladder adjusts to the obstruction or the blockage. And what happens is, as this blockage develops, it's a progressive, it can occur over years, the bladder makes some changes. Initially, when the prostate obstructs the flow of urine, the bladder will thicken. It's like lifting weights because it has to work against that obstruction. So the bladder wall, which is muscle, will thicken, and as it thickens, it can increase the pressure and improve the flow. But there are limitations to how much thickening can really work against a progressively enlarging prostate, which is causing more and more obstruction. So the bladder then starts to stretch. It enlarges to accommodate the urine that it can't get out. And so when we check the bladder in a man who has significant symptoms of BPH, you'll find that there is residual urine. You urinate, we check you, we do what's called a post-void residual in your office, and we find you have a fair amount of urine still left in the bladder. You're not sensitive to it because over time, the bladder desensitizes and it accommodates that urine. Otherwise, you're probably in the bathroom every minute or two. So the first compensation is the bladder wall thickens. The second is that the bladder enlarges to allow and accommodate the urine. And of course, is this progressive retention, catheter, and of course, unfortunately, when there is retention, this backup of urine, this is a plumbing system, backs up into the kidneys, and unfortunately, there can be kidney failure or renal failure. So that's the progression, and that's what can happen as BPH develops and progresses. So if those are symptoms that you're experiencing, it's important to make sure that you see your urologist and have them evaluate you, because there are other conditions that can cause you to urinate frequently. We have high blood pressure with the medications that are used to address high blood pressure. And some of these medications, they contain a diuretic or a water pill that makes you urinate a lot. Diabetes, when there is poor control of diabetes, there's sugar in the urine. That sugar causes you to urinate more frequently. It pulls water out of your body, and that's one of the things that tells you that diabetes is not well controlled, that it will cause you to urinate very frequently, okay? More frequently. So you've been diagnosed with benign prostatic hypertrophy or hyperplasia. You go into the office, the urologist is going to evaluate you, wants to do the things we just talked about. He going to ask you questions. He's going to want to check your bladder to see how well you empty. He's going to do your PSA. We're going to talk about prostate-specific antigen, which is a blood test that obviously we use to screen for prostate cancer, but it's an important test to do when you're evaluating someone with benign prostatic hypertrophy. And as I mentioned before, he's going to check your bladder to see how well you empty. One of the first options in managing, and once we've concluded it is just BPH, is medical management. This medical management consists of pills, oral medications that can help you to pass your water much more easily. And one of these drugs, many of you may have heard about it. They're called alpha blockers, Flomax, Rapaflo, Uroxetrol. These are medications that are commonly used as one of the drugs in the management of BPH. What it does is that it relaxes the muscle in this area, in this prostate area. It relaxes and allows easier passage of the urine and can increase and improve your ability to empty, and it can diminish the number of times you end up having to go to the restroom. So there's another agent that's typically used in the management of BPH, and they're called 5-alpha reductases. And these are medications that you may have heard of as well. One's called Avodart and Proscar. And these medications work by blocking a hormone, testosterone. It changes that hormone so the testosterone does not affect the prostate and causes it to grow and continues growing. So with the use of this medication, it blocks the active form of testosterone, and you can actually get shrinkage of the prostate. It may take several months, but it is helpful in reducing the size of the prostate and addressing those symptoms that we spoke about, as well as decreasing the likelihood that you will ever develop retention and may end up having to have a surgical procedure to address BPH. So, medical management, first option. Of course, once you have been given a trial, you should be followed up within a short period of time and determine if the medications that you're on is working, and it's diminishing your symptoms. It's improving your ability to empty your bladder, okay, and to make sure that, again, symptomatically, you're better with the medication than you were without it. Now, there's some other medications that are used for BPH. One is called Cialis. Many of you may have heard it. Cialis has two uses. One, it is used to treat erectile dysfunction, difficulty with achieving and maintaining erections, but it also has been found to be effective in treating BPH. And it's taken daily. So it's a small dose, 5 milligrams once a day, which can be used in place of Flomax, Uroxetrol, to manage BPH, and it has the second benefit of being able to address erectile dysfunction. Now, most of the pharmaceutical plants is going to requires that you give a trial of those alpha blockers, Flomax, before you're able to use the Cialis. But it is effective, and I've got a number of patients who have been on it, and it works. Now, there are surgical options for the management of BPH. We break it down into we call minimally invasive options, and you may have heard of these procedures. One is called Resume, and another was called Urolift. Now, these procedures are called minimally invasive because they're done on a same-day basis. They take a few minutes, and again, it's done under typically sedation, IV sedation, and many of these procedures take no more than 15 or 20 minutes. Resume uses heated water, which is injected into the lobes of the prostate. We use a scope. We go in through the channel. We inject water into lobes of the prostate, maybe 6 or 8 different areas. Now, that heated water over time, meaning within 2 to 3 months, will cause shrinkage of the tissue and thus allow for easier passage of the water. Does it work in everyone? No, but a majority of patients benefit from it. It can provide relief for 5 years. Urolift is a procedure that uses clips, and these clips are used to kind of clip the prostate tissue and open up a channel. It's a foreign body being put into that area, but it can open up the channel and again create easier passage of the urine. Now, the more invasive options, you may have heard of green light laser, which is using a special device that emits high energy radiation called a laser that basically will vaporize the tissue. So you're creating a channel with this laser, which vaporizes and sort of melts tissue as you pass the light over the tissue. And that creates a channel, removes the obstruction, and allows for easier passage. Done on a same-day basis as well. A little more, much more invasive than those first 2 procedures I just talked about. The gold standard remains the scraping of the prostate called a TUR prostate. And we use an instrument with a loop, an electrical current, and as you touch the tissue, as you move it, it will excavate and scrape away a small bit of tissue at a time, each time you move it or excavate. And by the time you finished, it may take an hour, you have created a nice channel, which will allow, after healing, nice passage, a good passage of urine. Of course, that may require an overnight stay in the hospital, but of course, it's a much more durable procedure, meaning it'll last much, much longer, more years. Now, some prostates are so large that scraping, green light laser, are just not adequate because prostates are so large. And if we are sure that this is simply benign enlargement, one of the procedures that can be done is called a robotic simple prostatectomy. Not a radical, but a robotic simple prostatectomy done with the robot. And the prostate tissue is sort of enucleated. So you leave like an orange and you're going to scoop out the meat from the orange with the robot. And that basically will remove the obstructing prostatic tissue. So we're talking about significantly enlarged prostates. We're talking about prostates over 100 cc's plus. And I've had some of my colleagues do prostates as large as 300 small oranges or even bigger. And the simple procedures we talked about are just not adequate. And they don't do a good job of removing enough tissue. And what will happen is that you're going to need a second, maybe a third procedure if you don't choose the proper procedure the first time. So treatments, minimally invasive, and of course, the more invasive and aggressive options, TUR prostate, green light laser, and of course, a robotic simple prostatectomy. Let's allow some time for questions about BPH. Yes, sir. When we talk about prostate cancer, we're going to talk about that in a minute. And yes, obviously, that's called a radical prostatectomy that involves removing all of this. Yes. Any questions about BPH? Okay. Yes. One time. You one sitting, you have a special instrument, and that instrument has a scope, and it has a small device, maybe the size of a tip of a pen, that you penetrate the lobe of the prostate. You press a button which injects fluid for about 8 seconds into each of the lesions that you may treat. So, an average prostate of 60 grams, you may have to do it six times. Any other questions about benign prostatic enlargement? No. Okay, let's move on to prostate cancer. So, prostate cancer, something I'm sure that creates, testing 1, 2, creates a lot of concern for many of us. And I'm sure we know someone who has been diagnosed and treated for this disease. In 2022, there were about 270,000 cases of prostate cancer. Death rate, about 36,000 men died from prostate cancer. The good news is that 70% of these cancers are clinically localized, meaning that they are still confined to the prostate at time of diagnosis, which means they're amenable to cure. 5-year survival in those patients, 96, 98%. So no matter what you do, 5 years after being diagnosed with local adenocarcinoma of the prostate, that 96 to 98% of men are alive, and many of them are not going to be suffering any of the symptoms of prostate cancer. Now, unfortunately, men of African ancestry are more likely to develop prostate cancer than men from other ethnic groups. When diagnosed, they're more likely to have more advanced disease than men from other ethnic groups. And consequently, they're more likely to die. Now, there may be many reasons for this. Socioeconomic reasons, access, education, fear. There are a lot of things that I think drives this. But I think much of it has to do, though, with access and having the right kind of access. Now, of course, family history is also an important issue as well. Family and the history of family or prostate cancer in a family member increases the chances that you will develop prostate cancer. Of course, father, definitely. If you have a father and a brother, the chances increase dramatically. So, family history is something that I know I ask about, and I think all of us need to try our best to educate ourselves about that issue because I know there's many men don't like to talk about it, and obviously uh, there's a lot of secrecy, and it can be difficult, I think, to engage family members in this conversation because again I've been doing this a long time, and I ask those questions, and I understand it can be a very sensitive subject matter, but it's important to know your family history. Now, how do we go about testing or screening men for prostate cancer? A test called PSA is an important screening test. PSA stands for prostate specific antigen. It's a blood test. Pretty simple test to do. I think they offered testing here. The second part of that screening is the dreaded rectal examination, where there's a need to examine the prostate, touch it, and you're evaluating the size of the prostate, but also more importantly, the consistency of the gland, because a firm prostate raises concerns about cancer. The prostate should feel, we call it the thenar eminence. It should feel like this part of your hand. Okay, when it starts to feel like the tip of the thumb, or the first joint in the thumb, where it's hard, we call that nodularity. And nodularity raises concerns about the presence of cancer. So, thus, the importance of not only testing and drawing blood tests and doing the PSA, but also examining the prostate with the finger. When should we start screening men for prostate cancer? With a family history of prostate cancer, it's important to start early, meaning in the early 40s. So if you have a father, brother who have prostate cancer, the screening starts in their 40s, before 45 years of age. And that means PSA screening and the rectal exam. Men who are not subject and don't fall into those risk categories, but again, African American men are at higher risk to start with. Okay? But it is safe to start in your 50s and early 50s in screening. And that's the American Urological Association, American Cancer Society, all advocate for screening to start in the 50s in the absence of any increased risk factors, meaning families with prostate cancer, father, brother, etc. Now, what's interesting is when we talk about genetics and cancer in families, one of the issues that's talked about is presence of breast cancer in women in the family, and there's a connection between breast cancer and prostate cancer. So, yes, sir. The issue of cancer screening, prostate cancer screening, and ages at which you should do this is something obviously that's subject to some controversy, but you're right in that men who are approaching that age of 70 who are older than 70 are not going to be screened with the frequency, and they're not probably going to be required to undergo the rectal examination as men who are younger than 70 years of age. I don't subscribe to that. I have diagnosed cancer in men older than 70. I think you have to also weigh the physical wellness and physical health of that person. Okay, that's not all 70-year-olds are the same. Not all 80-year-olds are the same. But I think you have very viable, very healthy, very active 70-year-olds who come to the office and we talk about it. It's not something I just ignore and just don't discuss. I discuss the age. I discuss the need to proceed with cancer screening, and I give the patient and I explain to the patient the option, and I give them an option. I simply don't stop doing it. We talk about it. We discuss the pros and the cons. We discuss current recommendations, and I allow the patient to make an informed decision as to whether or not they want to proceed and continue with screening. That answer your question? Thank you. I am a practicing urologist. I practice in northern New Jersey for a large urology group. My name is Dr. Johnson, George Johnson. I'm board certified in urology, and I'm still currently practicing. Mhm. Sure, we can talk about it. Yeah, I'll discuss that. An active thrill. Sure. All right. So let's do this. Make it maybe a little more interesting. Let's go through a scenario. Let's go through a patient that's sent to the office who has an elevated PSA and how we work through that. Okay, and we'll touch on those things that you questioned. All right. So, 58-year-old comes to the office, sent by his medical doctor. He's done a yearly physical examination and has been found to have a PSA of 5.8. Normal PSA in a 58-year-old, 4 or less is considered normal. So this PSA is 5.8. So I question patients about their symptoms. I want to know, are you urinating a lot? Have you seen blood? Is there frequency, urgency, nighttime urination? Do you have any burning on urination, which could suggest the presence of an infection? Because PSAs can increase related to a urinary tract infection. So we must rule that out. Um, so we get a medical history. We want to know about other medications and medical diseases that this patient is suffering from. And the next thing that we want to know is we want to know about other PSA levels, because one PSA level is not sufficient to make determination as to what has to be done in terms of a workup. So what I would then do is, after I've gotten that family history, is there any family history of prostate cancer? Is there personal history? We'll do the physical exam. We check the prostate. We do a digital, and we want to draw a PSA before I do that digital, because I need to know, is that 5.8 today, which was done a month ago? Is it going to be 6.8? Is it going to be 6? are we able to confirm that there's an elevated PSA? At the same time, at the same sitting in the same office session, I discuss the workup. What do? We have to say if we have a repeat PSA and it comes back 6. So we have 2 PSAs. We've confirmed that there's an elevation. What other ways can we gather information to determine the need to proceed with a biopsy, which is the test that we ultimately have to do to diagnose prostate cancer? The PSA does not diagnose cancer. The digital examination does not diagnose cancer. We can do what's called an MRI of the prostate with and without contrast. Okay? An MRI is an imaging study called magnetic resonance imaging, which allows us to get a picture of the prostate and determine if there are any abnormal areas of the prostate that's suspicious for cancer. MRI is graded from 1 to 5. It's a radiographic or radiological, grading system. 1 and 2 are benign. 4 and 5 are highly suspicious for prostate cancer. 3 is middle of the road, kind of equivocal, not here or there. But if we find that the MRI is 3, 4, or 5, that's the basis to consider what's called a fusion biopsy. With 2 elevated PSA and abnormal MRI, you have sufficient indication to do a fusion biopsy. And what is a fusion? A fusion is simply the MRI is used as a template. There's a spot on that MRI. We use an ultrasound imaging that's superimposed on it. That ultrasound is used as the guidance mechanism, and we're able to move the needle that we're going to use to do the biopsy right to that spot and obtain tissue from that suspicious spot. So that's the purpose of using an MRI in the presence of elevated serum PSAs. Further, gather additional information with which to say we should or should not proceed to a biopsy. Is the MRI a diagnosis? No, it's not. Tissue is what determines the presence of cancer. So if a patient, yes. Well, the purpose of the MRI and the reasons that it's been advocated or recommended is the belief that it will find more significant prostate cancer. Okay? Prostate cancers are graded from low risk to high risk. And low risk cancers are typically not going to be aggressively treated and may be observed, depending on, again, the volume of disease. More and more of them are going. No, it's not. More and more of them are having MRIs before the biopsy. Okay, but sometimes what happens, they may have a biopsy, but before a second biopsy, definitely I do an MRI. Okay, but it goes both ways. But more and more patients are getting MRIs who present with elevated PSAs before they have their first biopsy. Yes, sir. Yes. African men of African descent. You see increase. Yes. 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 You do. Genetic access is something that is an issue, of course, right? Well, it's hard. It's hard to change one's genetic predisposition to disease. I think it's just like women with breast cancers and their genetic predisposition. It is definitely hard to do it. It's not something that's easy to do. You know that you can screen people. You can find out if if they have a tendency to develop a disease, and you may have to take the necessary steps to try and find or diagnose that disease in its earliest stages, so you can treat it and ensure that survival of that host. But trying to alter, I think genetic, we're not. I think we're not at the point in time uh, that we can alter genetic predisposition. I guess it's coming, but we're not there. Okay. Thank you.